Welcome everybody, good morning. I feel like a rock and roll star, so I have to profit this moment, the unique in my life. So I just would like first to give, to apologize, because you will see I've tried to, or we've tried with Dennis to summarize the best abstracts, but this is just impossible to do it in 15 minutes. So what we've done and we will try to do is to walk with you to the main topic that have been touched both in basic science and in clinical science, and trying to just put some of the maybe most illustrative works that have been shown during the Congress these last 4 days, showing these different topics. So before going through, these are my disclosures. So just before starting with the main basic science, just to show you the amount of abstracts that we have received this year in the ESOT, up to almost 2,000 abstracts were received, so increasing every year in the ESOT presentation. As you can see here, they were divided in novel formats that I think everybody has enjoyed, such as the elevator pitch, brief oral, and so everybody had the opportunity to explain their works. And also, it's been amazing the number of attendees that have attended the Congress. You can see that almost 3,500 people has attended here, and also up to almost 2,000 have followed the Congress online. So we have received abstracts from all over the world, mainly, of course, from Europe, but also just make attention to this 30% of abstracts from Asia and the Middle East. And just to show you the main countries that have contributed, so the UK, Spain, Republic of Korea, with more than 100 abstracts submitted to here, so plenty of fantastic works. Regarding the main topics, these are kind of overlapping because most of them were clinical works, but also, as you can see here, clinical and translational were also main interesting themes that we have listened. And regarding the type of solid organs, as you can see, and as usual, kidney transplantation has been the most worked solid organ transplant, but also liver, and then lung, kidney, and pancreas, and also other topics such as donation, ethics. We have for very, very interesting abstracts. So, and then just to see how biased Dennis and I we have the opportunity to see the most through the application of the Congress, the most viewed abstracts of this Congress. Here you are. So congratulations for all of you. But we did not do it that bad, Dennis. So more than 60% we have summarized it in our presentations. So here we are. So let's start with the basic and translational science. And many words have deal with basic immunology, and basically trying to understand which kind of immunosuppressive drugs influence autoimmune regulation in experimental models. And coming from Vienna and expanding from their previous works they have showed that low-dose CTLA-4 they could achieve partial survival of a pretty stringent graft model of fully mismatched heart transplant. They aim to increase the population, which was dependent on regulatory T cells. They add the IL-2 complexes, IL-2 and anti-IL-2, and as you can see here, they achieve long-lasting survival, and they demonstrate that they could increase the number of regulatory T cells as compared with CTLA-4 low doses alone, and also the downregulation of the B6, the B7 or CD80, CD86 molecular inhibitor family was also downregulated in APC, so suggesting that by adding this IL-2 complex, we increase the regulatory T cell numbers. Also, the same group also investigated these complexes, these IL-2 and anti-IL-2 antibodies, but also adding anti-IL-6 as an anti-inflammatory molecule to induce, and also in a very stringent model of a skin graft transplantation, BAL6 to a B6 mice, to induce longer graft survival, as was shown previously with islet transplantation. And as you can see here, what they show is that also is dependent from regulatory T cells. When you add an anti-CD25 monoclonal antibody, this tolerance is inhibited. They show very nicely how memory effector T cells are inhibited, and also de novo formation of de novo DSA are also inhibited. They show also that this donor-specific hyperresponse is not systemic, so they don't find this immune regulation in the periphery, because when they transplant a second graft, this tolerogenic state is immediately abrogated. Another very interesting approach is whereas CNI drugs really inhibit tolerance in animal models, and in this also stringent graft model of a skin transplantation coming from Regensburg, they tested the different doses of CNI drugs to see whether we could achieve long-lasting survival. As you can see here, only with high doses of TAC, this model of transplantation achieved a long-lasting survival. So they compare it with a co-stimulatory blockade protolerogenic therapy. As you can see, they achieve a significant survival, but not as good as with high doses of TAC. And when they add this low-dose TAC with this co-stimulatory inhibition, they increase survival. They show that this is dependent on the low-dose TAC. So when they withdraw TAC, this model, the tolerance is absolutely inhibited, or when they increase TAC doses is increased. So this is, and they demonstrate that this is due to fine regulation between effector and regulatory T cells, since when they adaptively transfer effector memory T cells, this tolerance is abrogated, or when they block with anti-TGF-beta, also this tolerance is also inhibited. And they also show that it was a local effect driven by an infiltration of regulatory T cells within the graft. And when they transplant a second graft, as you can see here, is immediately abrogated. So again, not a systemic effect, but a local immune regulation in these animals. So another very interesting topic has been whether the expansion ex vivo of regulatory T cells can induce allograft tolerance, also in humans or in humanized tissues. And expanding from previous work, the group from Nantes also aimed to understand whether what they had previously shown, that there is probably a novel regulatory T cell subset within the CD8 positive compartment expressing CD45 are still low, whether in human beings are also present. As you can see here, they show very nicely that indeed they can show these CD8, CD45 low cells which express high levels of regulatory T cells, IL-10, IL-34, and low levels of interferon gamma. And actually, when they do an allogenic culture, adding effector T cells, you can see that they inhibit this proliferation in a dose-dependent manner. And in vivo model, when they expand ex vivo these regulatory T cells and they add it, or they adoptively transfer these cells, you can see that this skin graft is tolerated also again in a dose-dependent manner. So again, a novel regulatory T cell subset that may have a potential use for cell therapy. Also coming from Regensburg, and as you all know, they have been working very much with another source of cells, regulatory macrophages. They just wanted to understand whether the immune regulation that these patients might achieve was driven by the induction of regulatory T cells. So they did a co-culture with allogenic T cells, and they show how they can expand induced regulatory T cells, and they find that they express high levels of TIGIT. So a co-inhibitor molecule, which is expressed on Tregs, they show that this expanded or induced regulatory T cells express high levels of FOXP3 and IL-10, and most importantly, when they go to the patients before transplanting and after infusion of these MREGs, they see how these regulatory T cells progressively increase, and they express this TIGIT co-inhibitor molecule, and it is maintained after transplantation. They can even show that after 8 years in one patient uniclonality analysis, they can find these high levels of regulatory T cells in this patient. So a potential mechanism of regulation of adoptively transferred regulatory macrophages. So regulatory adoptively transfer of regulatory T cells has also been tried in a stringent model of transplantation of a composite vascular allograft. And as you can see here, is achieved by combining a co-stimulatory blockade with rapamycin and T cell depletion, and also the transfer of both donor or recipient regulatory T cells. So not only solid organ, but also a vascularized composite allograft is able to show long-lasting survival with this combination. So regarding histocompatibility and immune risk stratification, we have learned a lot, and we've seen that this is not that easy as what we're doing in our clinical practice, just dealing with the allele at the allele level of matching donor and recipient. And we've heard two amazing works coming from Cambridge or Berlin, in which they found that we can also match patients according to electrostatic mismatch score, according to physicochemical properties of the amino acids of the HLA molecules from donor and recipient, or also taking into account the epitopes that are expressed, but that are only going to be presented by the indirect pathway, which would be the one who plays a main role after transplantation. As you can see here, they show very nicely in a very large cohort of patients, 11 and 10, 11,000 patients in the UK, or 2,700 patients in Germany, how by matching those patients with the worst matching at this level show significantly worse outcome in the long run. So again, maybe we will have to pay more attention to how we match in the future our patients. So many abstracts regarding anti-HLA antibodies, but maybe the most novel one that we've heard from the Paris transplant group was the one telling us that maybe those antibodies that are with a biological property that are able to fix complement might have also, or might be able to have a particular phenotype within the histology of these patients. So they follow a large cohort of patients. They made biopsy in those that developed de novo or DSA, and they found that some transcript could fantastically predict the presence of DSA with complement binding capacity much better than when we were taking into account only clinical or histological variables. In an unsupervised clustering analysis, they found that indeed the cluster A with rejection, with ABMR, were those, and patients were showing DSA with complement binding capacity were expressing these high levels of these transcripts, these particular transcripts. They went back, they did a post-hoc analysis of two randomized trials, in which the aim was to use eculizumab or anti-complement monoclonal antibody. As you can see, as compared to standard of care, only those with DSA with C1q positive were those that benefit the most of receiving this therapy. So again, maybe DSA alone is not enough to better stratify the risk of our patients. We also heard two works that maybe just looking to the DSA to antibodies is not enough, and we might be able, with new tools, to track donor-reactive memory B cells, and might be a new tool to predict rejection. An outstanding, I think, work coming from Stanford. In a very preliminary data, they told us that they are capable of sequencing the BCR repertoire of donor-specific memory B cells. So they expanded memory B cells from the circulation to obtain antibody-secreting cells, and using HLA beads from the donor, they are capable of accurately determine the BCR repertoire against the mismatch antigen of each patient. So a new tool to maybe accurately track the BCR and also even take the antibodies of these patients for mechanistic studies. But it's not only about the HLA-DSA, fortunately, and we've learned also that there are also other immunogenic antigens that might also have an impact in terms of graft survival. And very nice work coming from the Emmanuel Zorn in Colombia, in collaboration with the Paris group. They show that natural antibodies, those that we can detect because they react against apoptotic cells, they compare the presence or the advent of these antibodies as compared to pre-transplantation and after transplantation as compared to anti-HLA donor-specific antibodies. And as you can see here in the Kaplan-Meier curve, those patients with both DSA and natural antibodies perform significantly worse as compared to patients that only one of the two types of antibodies, and as compared to patients without antibodies. So again, another source of effector mechanism that might also play an important role. Another very interesting work coming from Lyon, they showed that maybe this microvascular inflammation that we find in our patients is not only driven by anti-HLA responses, but maybe also by NKs. And they developed a very fancy in vitro assay in which they try to find or look whether NK cells were activated when they didn't recognize the self class 1 mismatch. So they also proved this in a basic basic model of heart transplantation. And since NK cells, when they are activated, express mTOR, they treat these animals, as you can see here, with CNI or mTOR. And those that were treated with mTOR, they really showed significantly lower lesions after transplantation. So again, maybe another effector mechanism of rejection. Regarding biomarkers, thousands of abstracts, fantastic. I think the most important thing is that we learned that there are important networks, European networks, that are currently trying to validate new biomarkers or on the process of discovering new biomarkers, and a special attention maybe on the biomargin that we received many abstracts where they showed. I think it's nice to show the design of this study with a multi-step validation process among different groups, more than 1,000 patients, and they even showed us preliminary data of promising new biomarkers in the biopsies, in the urine, during peptides, or at the proteomic level. So promising data to come. And last but not least, we also heard very, very interesting works dealing with preservation and ischemic reperfusion injury, and particularly trying to see whether we can find novel targets to avoid these lesions through the induction of or the appearance of ischemic reperfusion. A very nice work coming from Austria. They used preliminary data from heart infarction dealing with toll-like receptor 3, and they show how after ischemia, these toll-like receptor 3 are significantly upregulated. They used a knockout model of toll-like receptor 3, and they induced cold ischemia time for 9 hours. And as you can see here, these animals, after this cold ischemia time, they showed significantly lower injury at the epicardium, at the myocardium, and significantly lower also inflammatory molecules in this particular animal. So a new target. And also coming from Cambridge, they evaluated whether warm ischemia time as compared to cold ischemia time could, through the evaluation of succinate, the mitochondrial succinate product, which is a precursor of ROS products, could also be a marker to be targeted. And as you can see here in this, they compare a model in mice, pigs, and also in human beings. As you can see here, succinate significantly increases after warm ischemia time, but not in cold ischemia time. So when they inhibited in a model of heart transplant, model with 12 minutes of warm ischemia time, you can see that the tissue succinate concentration significantly decreases, and actually the serum troponin as a marker of ischemia is significantly also reduced. So another potential and very interesting marker for DCD donors. An amazing also abstract coming from Leuven. They used the hypothesis that through ischemia, the genes that regulating fibrosis on the kidney could be hypermethylated and therefore lose their properties. As you can see here, they did biopsies, pre-implantation after reperfusion. And as you can see here, they found a generalized hypermethylation of the genes that were mainly controlling regulation of fibrosis in these kidneys. And actually, they found a signature of these genes that could outperform the prediction of chronic graft lesions in the long term as compared to just using clinical variables that we have. So again, targeting DNA methylation might be also another very important tool. And finally, the comparison in animal models of different machine perfusions to reduce ischemic reperfusion injury has also been a matter of work. And a nice work from London, from Imperial College. They they compare face-to-face normothermic and a hypothermic machine perfusion in a porcine ex vivo kidney model. As you can see here, while the hypothermic model improved significantly the physiological parameters in these animals. However, this approach did not show a reduction of the inflammatory transcripts in these animals, so suggesting that probably, despite that they ameliorate the physiology of this graft, they might increase the allogenicity through this inflammation on these animals. So a matter of debate, and a very, very, I think, cool experiment coming from Brussels. They aim to understand whether in the context of DCD, warm ischemia time, the initiation of a machine perfusion, whatever you want, hypothermia with oxygen or not, normothermia, started either right after procurement or late after on, could have an impact on graft function. As you can see here very nicely, they show that regardless the type of machine perfusion you use, but used right after procurement, so at the initiation, you can see that these animals show significantly better graft function as compared to a static cold storage. But however, if you put these organs late into the machine, you don't achieve this benefit at all. So in DCD donors, maybe as fast as we are reperfusing these organs, the better they will perform. And finally, how this IRI impacts on allogenicity. A very nice and basic model of kidney rat transplantation, stringent model with Lewis rat to Bron, Norway. They compared just an untreated animal to attack treated animals with a hypothermia oxygen perfusion treatment, the outcome of these animals. As you can see here very nicely, they show that similarly to attack-treated animals, the animals that follow the hypothermia show significantly reduction of the infiltration of CD, of macrophages, T cells, and less fibrosis as compared to the untreated animals. So the impact is better graft function and improved graft survival. And just to finalize, also we had the pleasure to listen to many new approaches dealing with bioengineering. And maybe just to illustrate, one example was this very nice approach of trying to successfully transplant a human tissue engineered bowel in an anthemic rat model. And as you can see here, using human source smooth muscle cells, where they were aligned and neoinnervated using also human source neuroprogenitor cells, they resulted in an intrinsically innervated smooth muscle sheet. So you see that they build this roll around, transforming them as a scaffold, and they implanted them in an omentum of these anthemic rats for neovascularization. They show that after 1 month, just 4 weeks after this bioengineered interstitial construct, show vascularization, normal cell alignment, phenotype, and most importantly, maintain their function. And I thank you very much for your attention.